and welcome to the Melanoma International Foundation Melanoma Research Alliance webinar series. This is Wendy Seelig, and I'm President and CEO of the Melanoma Research Alliance. Today, we are extremely pleased to bring you one of the foremost experts in melanoma, Dr. David Fisher, who will provide a Melanoma 101. We're incredibly excited about this topic given the recent advancements in the melanoma field, which have led to a brighter outlook for so many patients. Dr. Fisher is an internationally known researcher, clinician, and academic who is chief of the Massachusetts General Hospital Department of Dermatology. He also serves as director of the MGH Cutaneous Biology Research Center and director of the Melanoma Center at MGH. Dr. Fisher's research has focused on understanding the molecular and genetic events which underlie formation of melanoma, as well as skin pigmentation. As a clinician, he has worked to translate these understandings into advances in diagnosis, treatment, and prevention of human diseases related to the skin and associated disorders. Dr. Fisher is also a valued member of MRA's Grant Review Committee and Medical Advisory Panel. Welcome, Dr. Fisher.
Thank you, Wendy. It's a pleasure to be here. Over the next 40 to 45 minutes or so, what I will attempt to do is to provide a global review of the state of the field of melanoma. This is an extremely exciting field where there's been massive progress in virtually every aspect of our understanding of the disease, our understanding of how it forms, how it behaves, and very importantly, how to treat it more effectively. So without further ado, I will dig right in. So this is a monograph that describes one of the very first descriptions of the entity of melanoma. This is from back in 1857. Melanoma has a rather distinctive history in medical history because, unlike many other types of cancers, it had the distinction of being pigmented. It was black. And for that reason, although most of the early descriptions involved the pathologic features and surgical approaches to treating the disease, there really weren't much in the way of medications. In fact, there was a fair bit of accuracy to those descriptions because what they were describing really was melanoma due to that, the accuracy of being able to recognize the dark pigment that was present. Where does melanoma occur? Melanoma starts in the skin, and it starts specifically in the region of the skin known as the epidermis. If we look here at these anatomic regions shown on the left, the epidermis is actually the very most superficial region of the skin. The dermis is deep to that and the hypodermis beneath it. Melanocytes, pigment cells, live in the epidermal layers, the very most superficial layers of the skin. And it is there that they produce pigment, and in fact, most of the pigment is actually not contained within the melanocytes, but it's exported to other cells overlying the melanocytes within the epidermis. This is shown on the next slide, where you can see a high-powered microscopic view of what normal skin looks like. This entire purple region is the epidermis. Whoops. The epidermis contains mostly keratinocytes, and a very small number of cells indicated by these arrows down at the base of the epidermis are the melanocytes. So in fact, melanocytes are a minority population in our epidermis, and this is actually identified with a very specific stain on the slide on the image to the right. And what we can see is that although melanocytes are relatively uncommon cells within the epidermis, their activity in producing pigment produces a very dominant phenotype. We see this. You can identify pigment differences between people extremely easily, and the reason for that is that the pigment, while being synthesized in melanocytes, is exported out to the overlying keratinocytes. So most of the pigment in your skin actually resides in keratinocytes, and the melanocytes synthesize it, but then secrete it back out in these little vesicles called melanosomes. This is fundamental to the biology of pigment production, and it is probably critical that the pigment resides throughout the epidermis because it's there that it's able to provide a kind of a cloak to produce a shielding effect from ultraviolet radiation that protects our skin. So what do we know about the melanocyte lineage, that cell type which can give rise upon malignant transformation to melanoma? So melanocytes actually are a very distinctive small population of cells with a number of features that are not shared by many other cell types in the body, such as the keratinocytes or the other deeper cells within the skin. Melanocytes are different. Melanocytes are derived during the development of our organism from a structure known as the neural crest. And the neural crest arises along what during embryonic development really represents sort of the backbone area. This is an area where precursor cells, stem-like cells, are able to differentiate into a number of different lineages. And melanocytes come from a common precursor that has the alternative of turning either into nerve cells, neurons, glial cells, which reside next to neurons, or melanocytes. And so there is a three-lineage partnership and a stem cell that can give rise to any of those three. And in fact, there are diseases, there are malignancies in which we see similarities based on that embryonic relatedness of melanocytes to these other cell types. During development, during embryonic life, these various cells migrate out of the neural crest, and here you can see in an image on the right, this is actually an image of, I believe, a chick embryo, in which each melanocyte has been labeled with a blue dye, and each dot represents an early melanocyte precursor coming out of the neural crest, and you can see towards the head region, this is the head region, this is the tail region, these cells are starting to migrate out of that neural crest region towards the skin. Down towards the tail, they're still sitting in the neural crest area. And this represents that process of neural crest migration. Because the melanocytes are so migratory in their embryonic stages, we believe that this carries over to the behavior of melanoma, which unfortunately has the propensity to be very migratory, very invasive, and unfortunately has a high chance of metastasizing. That probably, in the cancerous state, is a mimicking of the embryonic behavior of melanocytes during early development. When we think of skin pigmentation in humans, there have been attempts to classify the skin pigment types. And this is the most popular classification schema. This was known as the Fitzpatrick phototypes, and there are types 1 through 6. And what these represent is a distinction of the color of the skin from the fairest, lightest color all the way down to the darkest color that one is endowed with at their birth. And it turns out that as one goes from the lightest skin to the darkest skin, there are also a number of other correlates that go hand in hand. For example, the MED is the minimal erythematous dose. This is the lowest dose of UV ultraviolet radiation that would give a burn. And you can see that as one's skin becomes darker, one can tolerate a higher and higher dose of ultraviolet radiation before burning. We can see that that tends to correlate, that as you get darker and darker skin, one's sensitivity to ultraviolet radiation goes down. And correspondingly, one sees these behaviors that are very well known to most people. Light-skinned people burn easily and tan very poorly, whereas at the other extreme, people with darker pigment tend to burn minimally, but to tan very well. All of these correlates turn out to be extremely important in helping us to predict who is at risk, and in fact also in helping us identify ultraviolet radiation as a particularly dangerous risk for the formation not only of melanoma, but essentially all, or certainly all, common forms of skin cancer, even non-melanoma types of skin cancer. So here are several key features of melanoma that we believe are terribly important if we are to try and impact the terribly high incidence of melanoma in our populations. And I would raise this point quickly at the beginning of my lecture here, because although many melanoma patients may have curiosity about therapies, and certainly this is something we are obsessed with as well, we also know that melanoma patients also have an elevated risk of developing a second melanoma. And not uncommonly, melanoma patients may have family members who also have an elevated risk of melanoma, either because of shared exposures to ultraviolet radiation, or in a minority of cases because they may share genes or genetic propensity to develop melanoma. So I thought it would be potentially valuable to dwell briefly on some of these features of melanoma that set it apart. So firstly, the incidence of melanoma is increasing at an extremely high rate. That is to say, the slope of the incidence of melanoma is very high and for a while has actually been at the very top of the list, meaning that melanoma is increasing at a faster rate than virtually any other cancer. Now, this is a particularly troubling statistic because we probably know more about what causes melanoma than almost any other type of cancer. And yet, one would predict for a disease where we think we know what causes it, ultraviolet radiation, we should be on top of that, we should be impacting that risk, and the incidence should at least be flat, but ideally even decreasing. And in fact, quite the opposite is the case. It continues to rise, and it continues to rise with a remarkably elevated slope. We do believe that melanoma risk is associated with sun exposure, but historically in human evolution, the state of skin pigmentation matched the exposure intensity of the sun. So people who lived around the equator where the sun was very intense typically had darker skin, and that was beneficial for the protection. People who lived at very high latitudes, Nordic areas, for example, here in Boston, that's relatively high latitude, would more likely have light skin. And these discrepancies in the matching of skin lightness or darkness relative to UV intensity are a relatively recent phenomenon over past decades as populations have shuffled dramatically throughout the world. And so as these discrepancies become more profound, very vivid examples being countries like Australia, Israel, Florida, Arizona, places like this, where light-skinned people are exposed to very intensive UV radiation, what we now see is that the overall risk for melanoma as well as non-melanoma skin cancer skyrockets. We believe that this linkage of skin pigmentation and UV exposure is tied during evolution to vitamin D synthesis in the skin. This is a very important pathway that during evolution was the only way, or one of the only ways of obtaining vitamin D. Nowadays, we don't believe that ultraviolet radiation is a safe way to achieve a healthy vitamin D dose. We recommend people check their vitamin D levels, have their doctor do it when they're checking their cholesterol levels and blood pressure. And if extra vitamin D is needed, there are simple, cheap, inexpensive, and highly effective supplements that one can obtain at any pharmacy. What are some features of melanoma? So the tumor is usually pigmented. It is often, though not always, occurring in sun-exposed parts of the body, that is to say in skin that is exposed to the sun. But melanoma, unlike other types of skin cancer, can also occur in places where sun exposure is not occurring, under one's trousers, under underwear, underneath a shirt, beneath your socks. There are features of melanoma that clearly increase the risk of this disease happening in a fashion that is not strictly tied to where the sun is being exposed on our skin. A significant fraction of melanomas, 10 to 30%, may not be pigmented. Those are called amelanotic melanomas. And these are scary in part because they may be more difficult to diagnose. And correspondingly, they may be diagnosed at a later stage, at a thicker stage, where the risk of invading, of growing vertically, meaning deep, and then potentially invading and metastasizing, that risk may be elevated. So amelanotic melanoma is a particularly troubling form in terms of early diagnosis and early cure simply by removing the tumor from the skin. What are some of the key risk factors for melanoma? Well, we know that changing moles can represent early melanomas. Dysplastic nevi, which I'll talk about a little bit more in a second, that is nevi with features that are atypical, particularly when they occur in a familial setting, that is to say other family members with melanoma, very large numbers of nevi, family members, a history of prior melanoma, congenital nevi, very large nevi that one is born with from birth, large regions of the skin that contain huge numbers of melanocytes due to these congenital nevi, slightly elevated risk from being immunosuppressed. There are many, many conditions of human health where the immune system is not working well. Certainly sun sensitivity in the form of people who burn very easily. This actually represents a modest elevated risk. This is not, or a slightly elevated risk on this table. We currently would say that for any individual, the risk is not huge. Collectively, in a population, this represents a very significant group of people from whom the incidence of melanoma represents a significant fraction of patients. So your red-haired, fair-skinned group, that freckles, more likely to burn, less likely to tan, this represents a very large population of patients from whom melanomas will develop, although the risk in any individual patient fortunately remains quite slow, and then they're quite low. And then there are populations in which the risk is lower than average, and these fortunately involve children, although the incidence appears to be rising in children and teens, and people with dark skin pigmentation typically have a lower risk of developing melanoma as well. What do we know about UV radiation? Well, there's a huge amount of information, and I won't go into all of it in detail in the interest of time, but we believe that in the case of melanoma skin cancers, that the radiation associated with that tends to be more intermittent high-dose, sun-burning doses intermittently, whereas non-melanoma forms of skin cancer tend to occur from ultraviolet radiation, which is lower dose but chronic. The farmer who is out in the field every day, that form of radiation is more likely to be associated with non-melanoma forms of skin cancer, and in fact, those are much more common than melanoma. These would be called squamous cell carcinoma or basal cell carcinoma of the skin. But the reality is that UV radiation of any, either intermittent or chronic forms, are associated with an elevated risk of both melanomas and non-melanoma skin cancers, and people who develop one of these types are at elevated risk of developing the other types as well. There are some features that confound our ability to understand the relationship between UV and melanoma, despite the fact that there is enormous confidence that UV is a major culprit. One of these is that there appears to be a long lag period between when the ultraviolet radiation occurs and when the tumor develops. And similarly, from the time that a primary tumor occurs on the skin, if it is removed by surgery, there can be a variable lag period. It can be short or it could be very long. It can be decades before a recurrence can occur. And therefore, the linkage between any individual lesion of melanoma and the actual cause for that lesion is often difficult for a physician or a scientist to determine with enormous accuracy, because there are clearly other events that are contributing, even though we know UV is one of those events and it contributes in an important way. We also know that melanoma can be one of the commoner causes of cancer that has metastasized to various organs in the body, but where one doesn't know the primary source of that tumor. So there is an entity in the field of oncology known as cancer of unknown primary, where perhaps there may be a mass in the liver or the lungs or various other organs, and one can identify that it is a certain type of tumor, but the pathologists have trouble identifying the origin of that tumor. For example, let's say it is not making pigment. Does that mean it couldn't be melanoma? Well, it could be an amelanotic melanoma. It might be a melanoma that doesn't make pigment, one of those minority types. Melanoma is actually one of the more common causes of cancer that has spread, where one may not actually even see the skin lesion that gave rise to it. There are lots of theories about how that might occur, that perhaps the immune system had destroyed the skin lesion that gave rise to the tumor, but for some reason had not been successful at destroying the metastatic disease. We also know that melanoma can spread either through what are called the lymphatics, which is an immune-related circulatory system, or the bloodstream, known as hematogenous spread. So there are a variety of ways that melanoma cells can spread throughout the body. Nevi are terribly important, and this is something that your dermatologist would be following on a routine basis, and we typically would follow on ourselves as well. Typically, they develop in early childhood and peak around puberty in the second and third decades, and then later on in life, they tend to regress They tend to disappear by the time we get much older. Nevi are associated with intermittent sun exposure, very similar risk factors as melanoma. And in fact, it's been suggested that chronic sun exposure might even be protective. And the reasons for that are probably complex, and I won't go into those today. Transformation from a nevus to melanoma is thought to be a very rare event. It's thought that the frequency is probably along the line of 1 in 100,000. So even if you have quite a few nevi, the statistical chance that one of them will convert into a melanoma, fortunately, remains extremely low. Nonetheless, if we go the other way and we look at melanomas that have formed in the skin and we ask, can we see a nevus there from which that melanoma has evolved? In fact, in probably 10 or 15, maybe 20% of cases, you can still see that there was a nevus there, clearly suggesting that the melanoma was derived from nevi. In other cases, melanomas probably did not happen through a nevus as a precursor. So nevi may contribute, but it's not necessary that they contribute as a precursor lesion to melanoma formation. We often talk about the ABCDEs of melanoma. These are some features that we try to pay attention to. Dermatologists, for sure, all physicians should, and actually patients, family members should as well. Asymmetry. Here is a symmetric lesion. Here is an asymmetric melanoma on the right. The borders, regular borders, irregular borders in the melanoma on the right. The color, a homogeneous color on the left, a heterogeneous color on the right that one sees in melanoma. The diameter, if one sees a lesion that is smaller than the size roughly of a pencil eraser, the statistical risk that it is a melanoma is profoundly lower. It becomes higher as one gets larger than 6 millimeters. But I should point out, still a very, very high fraction of those will not be melanomas. And the E represents evolution, change in the size, shape, color, texture, elevation, bleeding. Virtually any change within a pigmented lesion on your skin is a potential red flag that it should be checked out for the possibility that it could be either melanoma or a non-melanoma form of skin cancer. When we've looked molecularly at nevi, there are a number of mutations that are very, very common. The BRAF mutation, which we'll talk about in just a moment, NRAS, which we'll also briefly discuss, a common set of mutations involving genes known as the GNAQ genes. These are mutations that are seen in significant fractions of nevi. And as you heard, nevi, by and large, are completely benign, and they are not dangerous. There are a number of variants of nevi that we can detect and classify under a microscope, but the vast majority of these are enormously benign. They're things that in some cases have a slightly higher risk of transforming to melanoma, and for that reason, the pathologists spend a lot of time trying to classify these subtypes. Nevi tend to stain strongly for a protein known as senescence-associated beta-galactosidase. This is of interest because this is a protein that is expressed in cells that are undergoing a process we call senescence. And senescence occurs when cells have finished doing what they're going to do in life and essentially are becoming quiet, we call quiescent, cells that are no longer dividing, they're no longer functioning in a metabolically active way. They're sitting there, they are arrested in their state, and they are gradually perhaps drifting off towards dying at a later stage. So this is a behavior that one commonly sees in benign neoplasms, and it appears that nevi represent an example of that. The cooperating mutations and the sequence of molecular events that either produce nevi or produce the transformation of a nevus into a melanoma represent areas of active investigation currently. What are the correlations to melanoma risk? Well, dysplasia is something that is thought to correlate. There is a syndrome known as dysplastic nevus syndrome, and this is defined, as I'll show you in a moment, by certain features under the microscope. The number of nevi a person has correlates, as I mentioned a moment ago. The exposure to UV radiation correlates, but the exact risk is not really clear. And so at the end of the day, the linkage between nevi and melanoma exists, but the power of that and the ability to predict with much precision remains very, very imprecise. Here is an example of an individual with this dysplastic nevus syndrome. This person has numerous very irregularly shaped, irregularly sized nevi on the back. Here is an example of a dysplastic nevus, an irregularly shaped nevus, with a melanoma that is actually arising in that lesion. Under the microscope, there are a number of features of these nevi that one can see. This is a typical, well, I shouldn't say typical because dysplastic nevi by definition are atypical, but there are dysplastic nevi as shown here with what's described as severe atypia. And these are the types of lesions that on some occasions will trigger the dermatologist to seek a surgeon's doing a wider excision after such a nevus would be removed. And this involves features, histologic features under the microscope where there's a great deal of variability within the cell and other subtle points of how the nuclei and the cytoplasm of those cells appears. Melanoma in situ is a very early stage where the melanoma cells remain here, as you can see in the epidermis. They have not yet become invasive, and this is thought to be a dangerous lesion that may have a propensity, perhaps, to invade and spread to other areas. There is a lateral spread of melanoma. Here, this is a frank melanoma with malignant cells. The superficial spreading type is where it is thought that the spread is lateral, horizontal, in contrast to what's called nodular melanoma, where here you can make out this large region, but the melanoma is primarily growing vertically. It is growing as a nodule and has a high propensity to invade deeply. So screening for the skin, screening for melanoma, early diagnosis of melanoma, we believe is one of the most effective ways to catch the disease early, surgically remove it, and cure a patient. 6 of 7 patients are cured by simple surgical resection of their cutaneous melanomas. However, screening currently is not per se reimbursed unless there is felt to be a medical indication for it. So massive screening programs are not permitted at this point. They are not reimbursed. There is a political process around this issue that is felt to have resulted from a lack of sufficient evidence for impact on mortality. And this is because the studies have not really been carried out. They would take decades. They would take so many millions of dollars that it is probably not feasible to carry out those types of classic studies to prove a mortality benefit from skin screening. But there are a number of other strategies that are being pursued towards hopefully increasing the use of skin screening to try and catch melanoma earlier for many people. There is a procedure many will be familiar with known as the Sentinel lymph node biopsy, in which a nuclear tracer is injected at the site of the primary tumor, and it will be taken up at lymph nodes, which are known as the sentinel lymph nodes, the lymph nodes that are receiving the drainage of where that tumor happens to anatomically lie on the person's body. When these tumors are in the midline, the sentinel lymph nodes might be on both sides. They may be bilateral. The value of biopsying the sentinel lymph nodes, those that are draining the area where the tumor is that it allows one to focus in on the likeliest location of where melanoma cells may have spread. And that information turns out to be helpful for prognosis and helpful for what we call local control. That is to say, the area where those melanoma cells are less likely to have a local relapse if that involved lymph node has been removed. It is not so clear that carrying out this procedure alters the likelihood or the overall survival if melanoma has already spread to distant sites. In other words, the overall survival difference is either very small or non-existent for patients who have or have not had a sentinel lymph node biopsy. This is an area that is somewhat complex, and I would recommend people discuss this issue with their surgeon or their other oncologist or dermatologist if this issue is arising. It is valuable to have this information because it allows us to classify what's called stage 3 melanoma, and as I'll discuss in a second, adjuvant therapy is pertinent there. What is adjuvant therapy? Adjuvant therapy is one of the most important topics as we are now moving into our discussion here of therapeutics for melanoma. Adjuvant therapy is the form of therapy that is delivered in a person in whom you believe all tumor is gone. It has all been removed, typically after surgery. sometimes after radiation, but most typically it would be after surgery. But adjuvant therapy would be given to prevent the risk, the theoretical or statistical risk that the tumor may come back. If we think of breast cancer, a very high fraction of patients with breast cancer these days have their lymph nodes, a similar sentinel lymph node biopsy carried out, often under the armpit. And for patients, depending on the exact features of their breast cancer, even despite complete surgical removal of everything anyone can see in the breast, in the lymph nodes, adjuvant chemotherapy or radiation therapy is given and has been shown to profoundly improve survival and cure long-term from breast cancer. In the world of melanoma, there is one drug that has been approved for adjuvant therapy, and that is interferon alpha. The efficacy of interferon alpha is thought to be small. The toxicity is significant, and there are many physicians, many patients who have opted not to use interferon alpha because that cost-benefit analysis was not felt to be advantageous. We are now entering an era where the armamentarium of therapeutics for advanced melanoma, not where the disease has been entirely removed, such as the adjuvant condition, but our armamentarium of therapeutics is becoming much, much more active. And so an extremely important frontier for the coming years is to ask whether those treatments, when applied at the earlier stages of patients in the adjuvant therapy condition, where all gross tumor has been removed, but we still know that there is a significant risk of relapse, will some of those therapeutics have benefit in hopefully preventing for good the risk of any relapse occurring? So for the rest of my talk, what I'd like to move to is what I describe as the revolution in the therapeutics for advanced melanoma. And this is a very exciting era. Certainly there is an enormous amount of work ahead of us still, but we have entered an era in which the therapeutic opportunities and the progress, the rate of progress for melanoma is absolutely unprecedented. I'll be classifying the therapeutic strategies into two groups, the targeted therapies and the immunotherapies. Within the targeted therapies, I'll describe those which are targeting mutations, that is to say, specifically altered proteins due to mutations within the genome of melanoma cells. And I'll also describe targeted therapies which are not targeting a specifically mutated protein, but another protein that resides within a pathway that is known to contribute to the oncogenic, that is to say, the cancerous behavior of that melanoma cell. For the immunotherapies, there are a set of different strategies that have been employed, and I will touch on these as well as we come towards the later part of the talk. So the BRAF V600E mutation is one of the most common mutations known actually in all of cancer. This is a mutation that occurs in 2/3 of benign nevi. If you have a single mole on your skin, there's a statistically high likelihood that your mole contains this BRAF V600E mutation. This means that, in fact, the vast majority of BRAF V600E mutated melanocytes in the world are benign, because most moles are benign. And that's good news. It means that this mutant gene alone is probably not capable of producing a full-fledged melanoma. It probably contributes, but other hits, other mutational events must happen in order to convert that into a full-fledged invasive or metastatic melanoma. The incidence of BRAF V600E mutations in metastatic melanomas, in advanced melanomas, is a little bit lower than it is in benign nevi. It's about 50% of cases. And this is of enormous importance for our therapeutic armamentarium currently, because the mutation in this mutation in the BRAF gene results in the formation of an enzyme known as a kinase, which, rather than being available for appropriate control within the cell, activated when it should be activated, turned off when it should be turned off, instead of that, this V600E mutation that occurs in these patients results in a form of that kinase enzyme that is always on. It is constitutively active, and it cannot be turned off. It is, in a sense, stuck in the on position. And it happens that when this kinase enzyme is in the on position, it stimulates the melanocyte cell or the melanoma cell to grow, to divide. It stimulates it to be resistant to triggers of death, and a variety of features that would allow the melanocyte to become quiescent, to become quieter and no longer active. When the BRAF mutant protein is hyperactive in this fashion, but other proteins in the cell are not correspondingly activated, there is a kind of a chaos within the cell, and that is the state of a nevus. That is the state of a mole. It starts to grow, it reaches a certain size, and then it's stuck. And that is the benign proliferation that kind of outgrows itself, and then that chaos seems to trigger a senescence, resulting in a stable and, in the vast majority of cases, non-dangerous state of those cells. But if there are additional mutations that complement the BRAF V600E mutation, this can, in combination, result in frank invasive melanoma and metastatic behavior. The lucky feature of this enzyme, BRAF V600E, is that it has been possible to develop through efforts of numerous scientists and pharmaceutical and biotech companies a number of small molecule drugs that specifically block the action of that BRAF V600E that is stuck in the on position. And this is of enormous importance. Here is a depiction of the pathway that BRAF activates. So this is the normal BRAF protein, and this is the upstream pathway that activates either BRAF or a family member of BRAF known as CRAF. Either way, they result in the activation of another enzyme known as MEK, another enzyme known as ERK, and then ERK stimulates the cell to proliferate, to have enhanced survival activities. These are activities that normally help our cells respond. There are triggers that we need our cells to divide, we need them to survive, but normally what would happen is that this upstream signal would be present for a while and then it would go away, it would stop, and everything should stop, including the survival and proliferation. Cancer happens when instead we have the V600E variant form of BRAF. And this is a form of the enzyme that is constantly stimulating this pathway, and it is impervious to the upstream signal. So if RAS is no longer active, BRAF is still firing, and the only hope we have is to turn it off with these small molecule drugs. So two of these are vemurafenib and dabrafenib. These are both FDA-approved drugs. And in the case where a BRAF V600E containing melanoma is treated, a patient with such a tumor is treated with these drugs, we see a very high success rate in disabling the melanoma, at least in the short term, as I'll describe in just a moment. There is a subtlety in that the BRAF protein has a mild capacity to inhibit its family member CRAF. And as a consequence of that, when BRAF is inhibited, CRAF, if there are upstream signals coming into the cell, CRAF may hyperactivate this pathway downstream of BRAF. So even if you have this drug that is inactivating BRAF, suddenly CRAF has become hyperactivated. As you can imagine, this would give you an escape valve that allows the melanoma cell to keep on growing even though you are inactivating BRAF. And so for that reason, one can imagine that if we had another drug that activates this downstream portion of the pathway, MEK, and this would be a drug also FDA approved recently called trametinib, then the consequence is that you have inactivated the pathway at multiple steps, and the prediction is that you would see even greater benefit for the patient. Despite the fact that very high fraction of patients with BRAF mutated melanomas will respond to either single agent BRAF inhibitor or combination BRAF plus MEK inhibitors, nonetheless, we have the enormously frustrating circumstance where resistance occurs, meaning that the tumor with time has a reasonably high likelihood of eventually acquiring a regrowth property. And this frequency of resistance is one of the major challenges in the field of therapeutics for melanoma. There are two types of resistance. Relatively uncommonly, the melanoma with a BRAF mutation may be resistant acutely, meaning at the very outset of treatment with a BRAF inhibitor. While most patients actually see benefit, there is a subpopulation where intrinsically this tumor for some reason is not able to shrink in response to BRAF inhibition. In other cases, it responds beautifully at first, but may acquire resistance following a lag period of variable time duration. How does it arise? How can this occur? Well, as you probably know, in the whole field of cancer therapeutics for the last probably 50 years or so, the recurrence problem, the relapse problem, is the major issue that has made cancer so difficult to cure. There are many chemotherapy drugs that work for other forms of cancer, lung cancer, bladder cancer, prostate cancer, that may work acutely, but eventually they don't seem to work anymore. So this problem of resistance, the acquisition of resistance with time, in a sense is not unique to melanoma, but there is something unique in this particular case of resistance to a BRAF inhibitor. And the difference is that we have a lot of information about how the BRAF inhibitor works. And therefore, we have a huge shortcut to figuring out where the resistance arises, and most importantly, how can we hamper that resistance mechanism? How can we attack it? And how can we hopefully turn the efficacy of a BRAF inhibitor into an even greater nuclear bomb against these BRAF mutated melanomas? So what have we learned? We've learned that resistance to BRAF inhibition arises in part from the great heterogeneity, the variability of the cells within a melanoma. While they are all melanoma cells, and many of them may be pigmented, and they all contain the BRAF mutation, there are additional mutations that are occurring during the ongoing evolution of a melanoma's growth. And therefore, there are new little subclones, pockets of cells that can acquire different features that allow the cells to become resistant. But again, they must somehow deal with the pathway that BRAF drives in order to be a melanoma cell. So how do they ultimately become resistant at a molecular level? Well, one approach is to alter the BRAF, alter that BRAF V600E protein such that the drug no longer is able to inhibit it. And there are these various events, one known as alternative splicing, a complicated RNA-based mechanism. The gene, the copy number of the BRAF V600E may amplify so that instead of just having 1 or 2 copies, there may be 5, 10, 50 copies of that gene, and therefore that same dose of drug is not able to inhibit the BRAF V600E protein. There are new mutations that may rescue that pathway and go around the mutant BRAF, so that even if BRAF has been disabled, other mutations, as listed here, are able to go around through CRAF to reactivate the pathway downstream. And in some cases, there are alternative pathways that completely rescue even the need for this MAP kinase pathway, this very pathway that is typically activated by BRAF. And so the approach of combining therapeutics by attacking these escape mechanisms, such as by inhibiting MEK as a second nodal point further down in the pathway, has been the approach to favor. And as I described before, many of the resistance pathways still need to go through MEK, that downstream target of BRAF. And in some cases, as I described, BRAF inhibition paradoxically upregulates CRAF, and by having a MEK inhibitor, this will block that bypass mechanism of activation. And in fact, what we even see is that there is a lower toxicity when the BRAF inhibitor and MEK inhibitor are combined than when the BRAF inhibitor is used in patients alone. So I'm going to briefly describe one of the first immunotherapies that was used, and then I'm going to show you some of the survival curves and the clinical data that have validated the use of these various therapeutics and their combinations. So adoptive cell transfer is one of the most effective early forms of immunotherapy that was used. And this has a several decades old usage. Dr. Stephen Rosenberg at the National Cancer Institute is a major pioneer in this area. And what he did, and others have validated subsequently, is to take a melanoma metastasis, remove it surgically from the patient, and recognize the presence of tumor-infiltrating lymphocytes, cells of the immune system that were present within the tumor. Selectively remove these cells and grow them, amplify their numbers of these tumor-infiltrating lymphocytes using growth factors, such as one known as interleukin-2. And after these numbers have been increased to the billions, reinfuse them back into the bloodstream of the patient and allow these cells to attack the tumor. The idea being that if one is dealing with a battle, a tug of war between the tumor and the immune system, if you can take those cells for the immune system and amplify them outside of the body, now you can try to tip the balance in favor of the immune system and hope that those lymphocytes will go back, find the tumor, and destroy it. In fact, during the phase of this procedure where the lymphocytes are grown in the laboratory, it's also been possible to modify these in certain ways to try and enhance their ability to recognize and kill the melanomas. And this has been a source of major excitement because there have been some very, very profound remissions, patients where the tumors melted away, and that this was extremely stable. In other cases, that kind of a response did not occur, or the stability of the response was not as predictable. But I highlight this because it was one of the major clues to suggest that in many patients, there really can be evidence of an immune response that is present within the tumors, and when manipulated appropriately, can produce very, very striking effects in subsets of melanoma patients who undergo that type of treatment. Here is a survival curve from the initial clinical study from several years ago, back in 2012, which showed the benefit of combining a BRAF inhibitor together with a MEK inhibitor in patients with BRAF mutant melanoma. And what one can see here in the blue curve is the efficacy of a BRAF inhibitor alone. And then there were two different schedules of dosing, two different forms of giving the combination. But what we could see is that in both cases, the survival, what we're looking at here is the higher this curve is, the more survival, the lower it is, the less survival. And we can see that the combination of two drugs actually was improving the survival in a statistically significant fashion. These two drugs, dabrafenib and trametinib, have been FDA approved, and that combination is now very frequently employed as an option for patients who have BRAF mutated melanoma. Though still, as you can see, while there may be a high rate of response and it takes time before these relapses begin to occur, unfortunately relapse is still relatively common in this group, and so there's a huge effort focusing on trying to understand those mechanisms of relapse and add additional drugs to this armamentarium to hopefully bring these survival curves up to 100% with long-term disease-free survival. If there are lymphocytes, cells of the immune system, infiltrating in patients' melanomas, why aren't they destroying the melanomas? Why does this cancer exist? And we believe that the answer for this lies in the fact that there is a mechanism that's enormously important in our bodies to control the activity of the immune system in recognizing and destroying our own cells. This is a process known as immune tolerance, and it is a process that prevents us from having a category of disease known as autoimmune disease. There are a number of very common autoimmune diseases like rheumatoid arthritis, psoriasis, inflammatory bowel diseases. There are a number of conditions in which the checks that prevent the immune system from attacking our own cells have fallen by the wayside for reasons that are now only beginning to be fully understood. And it turns out that these immune tolerance mechanisms appear to be playing important roles in checking the immune response against melanomas. And this is not in all cases, because there are some melanomas that actually don't even have a lymphocyte infiltrate. But for those that do, it appears that in many cases, that immune population of cells, those lymphocytes, have been instructed by very specific mechanisms that are depicted in this cartoon. They have been instructed, those immune cells, to become quiet, quiescent, and not to attack the melanoma cell. Why would that be? The reason is that the melanoma cell is derived from the person's normal cells. The melanoma cell does not appear to be foreign. It is not foreign. It is not a bacteria. It is not a virus. It is not a fungus. And so the immune system is confused. It may see certain features on the melanoma cell that don't appear that they should be there, perhaps mutated proteins, but on the other hand, it may see other features that appear to be self, that appear to be normal, and therefore it's getting mixed signals. And if the net effect is to prevent the lymphocytes, to prevent the immune system from becoming sufficiently activated to kill the melanoma, if that does not occur, the net effect is that the immune response will lose and the melanoma will win. It will outgrow the immune response, and that is presumably the reason that there can be a festering immune response, but it is insufficient to prevent the melanoma from forming and progressing. With the recognition that there are these very specific immune tolerance mechanisms, it became possible to block tolerance. And the first drug that was shown to do this was an antibody that blocked one of these tolerance receptors. And this antibody generated the drug known as Ipilimumab, and the consequence of using this is that it releases the brakes. It blocks that checkpoint of tolerance and allows the lymphocytes to react against self. And hopefully, among the various self cells that it would react against are the melanoma cells. Predictably, there are also autoimmune side effects that one commonly sees in patients who receive Ipilimumab. They may develop inflammatory bowel disease. This is a common side effect, something that the oncologist has to watch very carefully because it can be extremely dangerous. And there are plenty of other side effects as well. These are very serious drugs. But the ability to block the checkpoint of the immune system appears to open up a whole new world of therapeutic targeting of the melanoma, where it is the immune system that is attacking. Again, reminiscent of that adoptive transfer strategy that had been tried decades ago. A second class of checkpoint blockade attacked a different tolerance receptor, what's called the PD-1 receptor. And there are several drugs. Nivolumab is one of them, and there are additional ones. Pembrolizumab is another, which has just recently been FDA approved. These are a different set of antibodies. They block a different target, and they produce a tolerance breaking effect that stimulates the immune response. And the initial evidence suggests that that immune response probably occurs in even a higher fraction of patients, and fortunately with an even lower risk of severe side effects than in the case of Ipilimumab. So the armamentarium of immune checkpoint breaking therapeutics is expanding before our eyes and changing the entire landscape of what is available for therapeutics of advanced melanoma. Here is the original study that demonstrated several years ago the benefit of Ipilimumab. This is the antibody against CTLA-4 as compared to a vaccine that was being used at that time against what's called GP100. And what you can see is whereas the vaccine had a relatively poorer outcome, Ipilimumab, with or without the vaccine, produced a beneficial outcome, that is to say, a lower mortality, not a dramatically lower mortality, but definitely a lower mortality. And this was the first major hint that immune checkpoint blockade is really producing this benefit. What is also notable is the fact that this curve is plateauing. And as you can see here, we're looking at months, really we're looking at years. And as we see these numbers becoming flat, it suggests that there is a population, and these were patients with advanced melanoma, metastatic melanoma, that there is a population in which this harnessing of the immune system was producing a stable condition. This is a condition where we hope that relapse will no longer happen. This is a long duration benefit. This is of enormous importance in ultimately what everybody wants, which is really a cure of the disease. Here is the initial study of antibody to PD-1, the Nivolumab that I described, a different checkpoint inhibitor. And what was shown in this survival curve here, each of these lines represents a single patient and how their tumor responded. So for example, in this particular case, the tumor grew, unfortunately. It progressed after starting the PD-1 antibody treatment. Here's another one that had actually progressed. But in the vast majority of tumors, what we see is sometimes the tumor shrunk very dramatically. 100% shrinkage means it completely disappeared. In other cases, it shrunk to some degree, but it did not progress. Again, there was evidence of very long-term, in this case, 1 to 2 year, stable disease. That is to say, it may not have shrunk entirely, but the tumor was not progressing. And this was a different immune checkpoint inhibitor strategy. And here is a similar type of plot, but being carried out in a study from about 1.5 years ago, in which anti-PD-1 and anti-CTLA-4 were combined. And this was now, in fact, a relatively toxic combination therapy. But what was seen here is that, again, unfortunately, there were a few patients in which their tumors continued to progress, although in some cases it was a delayed response that happened at a later stage. But in a very significant fraction, there were not only responses, but very profound shrinkages that were approaching 100% loss of those tumors. This is a very, very profound effect. There was significant toxicity because 2 different checkpoints were being blocked, and so a lot of immune side effects that obviously we need to understand better in order to optimize this form of therapy. So here we are. We have targeted therapies, we have immune-based therapies, and we have a lot of questions. We're seeing enormous benefits, but we're not there. We haven't reached the point where we can, with absolute certainty, predict who will benefit from each of these therapies. We have certain classes where we're better at predicting than others, but our predictability is not 100%. And worse than that, our ability to predict relapse, and more importantly, to prevent relapse, is also far from where it needs to be. So we need to ask some questions, and we need to do this in order to make further progress. So one very important question that has arisen is, what does the immune system recognize? If the immune system has been activated, what is it seeing on that melanoma? Because after all, the melanoma is derived from the person's own melanocyte. Has it just become an autoimmune disease and it's destroying all of the melanocytes? Or is there something about the melanoma that the immune system is recognizing? And there's been a striking clue about what it is the immune system sees. This has come from very deep genomic sequencing that has happened in the melanoma field. You've all heard, I'm sure, of the Human Genome Project, which has allowed us to interrogate the genome of our bodies, of our cells of our bodies. And that strategy has now been applied to many forms of cancer. And when we've looked at melanomas and compared them to normal cells from the same person, what was found is thousands and thousands of mutations that are recognizably derived from ultraviolet radiation. Thousands of mutations that probably reflect the history of that person's exposure to ultraviolet radiation throughout their life. And the vast majority of those mutations are not causing the melanoma. We call those passenger mutations. Only a few of those are driver mutations. The BRAF mutation, that's a driver if it's present in combination with certain other mutations. But there are thousands of passenger mutations that are not actually changing the cell's ability to grow. But what they are doing is that they may be altering the proteins in very subtle ways so that those proteins appear different to the immune system than the same state of those proteins in any other cell of the body, because those other cells were not exposed to ultraviolet radiation. And we call these altered proteins and these little amino acid changes on those proteins, we call them neoantigens. They're new antigens that are unique to the melanoma. And we suspect that the high exposure of melanocytes to ultraviolet radiation may be one of the reasons that melanoma has led this revolution of immunotherapy in the entire world of oncology, because melanoma and its genome is the most profoundly affected and the most saturated with mutated genes, these mutations having been caused by ultraviolet radiation. And interestingly, some recent research has suggested that some of these neoantigens may even resemble viruses or bacteria, thereby mimicking something that does look foreign, and thereby helping us understand why the immune system would now feel released to go off and attack and destroy those cells. And so these have been major clues of how the immune system works, how the immune system might not work when we are trying to use immune checkpoint blockade, and perhaps give us clues of how we can get it to work better. So as people have looked at melanomas and tried to predict those that will respond to these forms of immune therapy, immune checkpoint blockade, one concept that's come about is that those tumors that already have evidence of inflammation, they have lymphocytes involving and already infiltrating within that tumor, those are the more likely ones to respond to immune checkpoint therapy, whereas melanomas lacking inflammatory cells are much less likely to respond to immunotherapy. So a major focus right now in the field is to figure out how can we convert the sterile tumors, the ones that have no evidence of inflammation, how can we convert them to an inflamed state, and then perhaps they would be more amenable, more sensitive to stimulation of the immune system by these immune checkpoint inhibiting drugs. And I can tell you on the basis of the literature, on the basis of the meetings, on the basis of the word in the melanoma street, from the clinic, in the trenches in our clinics, at the laboratory benches, the buzz in this field is unbelievably energetic. It is unbelievably exciting because there are so many clues that come from these types of mechanistic understanding that allow us to test new hypotheses, and using laboratory approaches, in some cases with experimental models of melanoma, and rapidly translating these approaches to patients, we are absolutely convinced that we are only looking at the tip of the iceberg, and there is a great deal more to come. So on that basis, I'd like to end with the statement that I believe there's huge reason for optimism. We're living in probably by far the most exciting time in the history of this terrible disease, where we really believe that the tide is turning, and our ability to influence outcome and hopefully even influence the incidence of melanoma by appropriate behavior modifications and early diagnosis, that all of these things will lead us closer to the time when melanoma can be truly eradicated. Thank you very much.
Thank you, David. This is Catherine Poole, President and founder of MIF, and that was a really excellent slideshow. I certainly enjoyed it. It had something for all of our patients, from low risk to high, so thank you so much. I have one question for you to finalize this whole webinar, and that is, I wanted to know what you felt was the single most exciting thing that's happened for melanoma patients this year alone.
That is actually a really difficult question, and I'm happy to say that it's a difficult question. And the reason it's a difficult question is that there are multiple things that have occurred over this past year. I could even say over the past 6 months, that have transformed in an ongoing way the state of melanoma. We certainly are enormously excited about the adoption and FDA approval of immunotherapy, pembrolizumab, which is an anti-PD-1 drug, and the rapid testing of combinations of immunotherapy, as well as the increasing implementation of combination therapies for BRAF targeting for different patients. But what I would say, if I really had to put my finger on the single, to me, most exciting aspect of melanoma, where we are right now in 2014, is the fact that there is enormous ferment in the field The pace of discovery is absolutely unprecedented. The technologies to analyze melanoma, to analyze the specimens from our patients, to utilize the experimental tools of drugs, of preclinical laboratory models, has come together in a way that allows us to ask so many questions so quickly, and most importantly, to bring these back to the patients in the clinic and devise novel clinical trials and offer patients rapid testing of new concepts. I would say that, to me, the single most important thing, I can't put my finger on one discovery, but it is the fact that the body of discovery is moving collectively at such a rapid pace.
Great. Well, I agree. It's all of the above. And for myself, having been in this field for a very long time myself, it's been very exciting. And I want to thank you so much for your time today, and we hope you'll join us again.
My pleasure. Thank you.
Have a great Thanksgiving.
You too. Thank you.
Right.
Bye-bye.